Dear esteemed faculties and the delegates, warm greetings from the organizing committee. Never stop learning, never stop teaching. Knowledge dissemination is the ultimate. Track 2024 aims to empower and inspire, providing a platform for meaningful collaboration, connections, and learning. Over the next 2 days, we will delve into the latest advancements, challenges, and innovation in the diabetes management and care. We are thrilled to bring together legends in diabetology, leading experts and researchers across the nation to share the knowledge and ideas, experience in the prevention of diabetes and its complications. We are committed to making a positive impact on the lives of the people living with diabetes and their loved ones. Let us come together to impart knowledge on diabetes. Let us work together to prevent diabetes and ensure good quality of life to the diabetic population. I would like to extend my heartiest appreciations to the scientific committee and the organizing committee for crafting a truly exceptional scientific agenda for this track 2024. The carefully curated selection of topics, renowned speakers, and the innovative sessions will undoubtedly enrich our understanding of diabetes management and research. Warm welcome to all the delegates, faculties for the memorable experience. Thank you. Now let us hand over the first session to the chairpersons and the speakers. Please, thank you.
Welcome, Dr. Rajesh. He is going to talk to us on caveats in biochemical markers in diabetes. Dr. Rajesh needs no introduction. He is a very well known speaker in all diabetic forums happening in Chennai. Welcome, Dr. Rajesh, for the talk.
So, respected chairpersons, senior clinicians, and my dear friends, a very good morning to all of you. So, today I am going to discuss about caveats in interpreting. Yes. So, today I am going to discuss about caveats in interpreting the biochemical reports in diabetes. Yes. So, we all know that the biochemical reports, they form the backbone in diabetes management. And whether it is diagnosis of diabetes or whether it is follow-up of patients with diabetes or for prevention of complications, we heavily rely on these biochemical parameters. But we also know that interpreting these biochemical parameters in diabetes is not that very straightforward. There are so many physiological conditions, pathological conditions, as well as technical factors. All these things will influence these biochemical parameters. So, thorough understanding of these caveats is important. So with this, let me just go into this particular case. You can see, you can, okay. So you can see that the fasting and postprandial blood sugar are well under control, but the HbA1c is very high. Many a times we come across these kind of cases, and we know what is the reason. The patient's acute blood glucose control is acute levels are under control, but the chronic glycemic status is very poor. We know all these things. I'm not going into the details. But why do we have these kind of, apart from these factors, why do we have differences in the HbA1c? So, first of all, we know that there are certain limitations in interpreting your HbA1c. One is your anemia. In anemia, whether the HbA1c will falsely be elevated or falsely be reduced. For that, we need to understand it depends upon the red cell turnover rate. See, in conditions like iron deficiency anemia or hemolytic anemia, where the red cell turnover is very high, you can see the lifespan of RBCs are reduced. So there you can see that the HbA1c values are falsely low. And in conditions like B12 deficiency anemia or folate deficiency anemia, you can see the HbA1c will be falsely high in these patients. And we also know about the hemoglobinopathies as well as the sickle disease or altered hemoglobin which is present. All these things will interfere with the interpreting of the HbA1cs. And we have to be very careful in interpreting HbA1cs in CKD, because what happens one side there will be anemia, patient will be on erythropoietin therapy, sometimes patient would have received a blood transfusion. All these things are going to interfere with the HbA1c interpretation, and we know that there are some racial and ethnical differences in HbA1cs. And again, laboratory methods are very, very important. We know that the gold standard method is the HPLC method done by a D10 Bio-Rad, but there are other methods are also available, and you can see most of the laboratories do not follow the NGSP guideline program, and if you follow certain other methodology in doing HbA1c, sometimes there can be interference with the hyperbilirubinemia, triglycerides, or even alcohol intake can interfere with it. We all know about all these things. And again, when patients have conditions like iron overload, if there is a hemochromatosis, all these factors will again alter your HbA1c reporting. So we know all these things. We have discussed about the variations in HbA1c, the limitation of HbA1c in various forums. But let us look into what are the caveats in interpreting a blood glucose report. So here you can see you have whether patient has diabetes or not. When you are going to interpret these kind of values, you have a high fasting value of 137, which is in the diabetic range, and you have a postprandial value. What you have to find out is that first of all, whether it has been really done in the fasting state, which means at least 8 hours of true fasting should be there. And when timing of the blood sample collection is very important. Postprandial, whether it has been done at 2 hours after the breakfast. Sometimes we often see people taking very early, 1 hour, or sometimes even 3 hours, 3.5 hours after the breakfast also they take it. All these things will have an influence on the postprandial level. So these things we have to keep in mind. And also medications. We see in our practice that most of the medications, most of the patients do not take their routine medications before giving a postprandial level. Some people take half the medication, some people do not take medications at all. All these things are there. But apart from diabetes medications, there are also other medications. Suppose if this patient is on an acute dose of a steroid, or if the patient is on a high progesterone containing OCP pill, all these things also can elevate the blood sugar level. These things we have to keep in mind. And there are other conditions like endocrinal conditions like Cushing syndrome, hyperthyroidism, as well as acromegaly. All these things, you require that later? Okay. So all these conditions can increase the blood sugar level. And we also have to consider stress hyperglycemia. Suppose if the patient is going for a surgery or after surgery, or any physical stress like myocardial infarction or a stroke, in these conditions there can be stress hyperglycemia. And also when the patient is having infections, that also can push the blood sugar up. So these factors we have to keep in mind. And again, with respect to glucose metabolism, there are certain factors which will affect the glucose metabolism, like hepatic disease or renal disease, or sometimes malabsorption syndromes. All these things have an effect on the blood glucose levels. And sample collection errors, especially if they are collecting in different containers, on wrong containers, that will definitely have an effect on these values. And when you are doing an SMBG value, when you are doing a CBG value with the help of a glucometer, what happens when this patient is having some kind of a peripheral circulatory issues, like when the patient is having Raynaud syndrome or when the patient is having shock, all these things, all these times, what will happen? The blood glucose will be falsely low in these patients. And even alcohol consumption has an impact on the blood glucose level. It depends upon what is the quantity of alcohol and whether the patient has taken food along with alcohol or patient is in the fasting state. All these things will alter your glucose level. Either it will increase it or it will push the patient for hyperglycemia. So these things we have to consider. But having understood all these things, many times we come across our patients saying that, doctor, there is always a discrepancy between the lab blood glucose report as well as the glucometer report. Same time I am taking the, at the time when I am giving the sample for laboratory, same time I am doing a glucometer value, but at the end I can see there is a huge discrepancy in between the results. So what we have to understand is that when we do a laboratory value, what we actually look into the plasma glucose value, where the glucose concentration is actually 10 to 15 times higher than the capillary blood. Capillary blood is what we do with the help of glucometer. But again, let us understand that glucometers, the recent glucometers are all calibrated well enough so that even though when they are checking for the whole blood, they actually calibrate and project the values for the plasma blood. So that has been, it has been adjusted that. So that point we have to understand. Apart from this, hematocrit has an impact on the your SMBG values, glucometer values. If the patient is having high hematocrit like polycythemia, what you can see is that the glucometer values can go low, or if the patient is having anemia, the glucometer values can be falsely high in these patients. And again, another important thing is that the timing of doing laboratory blood investigation. So many times we come across this. So what happens is that phlebotomy will be done at one time, and the blood sample will be kept just like that, and it will be processed at a very later stage. Most often we see this sample collection, the phlebotomist come to the home for collecting the sample. Somewhere around 6 o'clock he comes in the morning, but by the time he goes to the laboratory and gives the sample, it will be somewhere around 1 p.m. So if there is a huge difference in the from the sample collection time and the processing time, what happens is that because of the glycolysis which happens in the RBCs, the values which will be done in the laboratory will be actually falsely low. So these things we have to keep into consideration. And again, variation with the glucometer device. All glucometers are not the same because the standardization is actually, we have to keep that in mind. And FDA has recommended that when the blood glucose values are above 100, there should be a minimum of 15%, only a 15% variation should be there. But if the glucose levels are less than 100, only 15 milligrams per deciliter variation should be there. So all these things are important. And again, not going into these details, even hypoxia will again affect your glucometer values. So again, improper sample collection, when the patient is having squeezing their finger excessively, or when the strip is not placed correctly, or if there are any outdated strips, expired strips if they are keeping, if the battery is not good in the glucometer, all these things will actually affect your glucometer values. Having understood this, let me just go into this particular case. Quite often we see patients like this coming with a very high fasting value, very high postprandial value, and urine acetone is negative. So from this value, can we say that this patient is not having acidosis? What we have to remember is that what we are doing here is only a urine acetone. Ketone bodies, we have 3 ketone bodies, we all know that. And ketone bodies are acetoacetate, beta-hydroxybutyrate, and acetone. Among this, in diabetic ketoacidosis, what will be elevated the maximum is your beta-hydroxybutyrate. So there will be 10 times elevation of beta-hydroxybutyrate compared to your acetoacetate. But what you do in the urine is not your beta-hydroxybutyrate, it is the acetoacetate. Acetoacetate will actually get elevated little later. But your beta-hydroxybutyrate only rises first, and it rises to a huge level that will be detected only in the plasma. So in the initial stages, suppose if your urine, there will be a lag time for the urine ketones to be present. This lag time can be somewhere between few hours to even 24 hours. So in the initial stages, if you strongly clinically suspect ketones positive in this patient, always rely on the plasma ketones, or else if plasma ketones are not available, what we have to do is that we have to repeat the urine ketones after few hours. So this caveat you have to keep in mind. So just because the urine ketone is negative initially, it doesn't mean that the patient is not having ketosis. And again, another important value report is this you can see the lipid profile. I have concealed the laboratory names. So you can see the lipid profile. This is a patient with diabetes. You can see the patient's total cholesterol is elevated. Serum triglyceride is 745, grossly elevated. HDL is relatively low in this patient. But when you look into the LDL cholesterol, you can see it is 30, well under the target. What is the target you expect in LDL you expect in patients with diabetes? It should be under 70. So looking at these values, we will go a little soft with respect to starting statins in these patients. So what actually happened here? Why is it? See, we all know about the classical dyslipidemia of diabetes. It will be high LDL, high triglycerides, and low HDL. But on the other hand, you can see that the LDL is low. What we need to understand is that in most of the laboratories, LDL is not calculated directly. It will be only by calculatory method. It will be frequently used formula is the Fredwald formula, where they calculate the total cholesterol, they calculate the HDL, they calculate the VLDL. How do they calculate the VLDL? They take the triglyceride and divide it by 5, and they minus the HDL and triglyceride from the total cholesterol. That gives you the LDL value. Most of the times, it correlates with your estimated LDL value. But what happens? When the triglyceride level is more than 400, we know that most of the time in hyperglycemia, triglycerides will be elevated. When the triglyceride levels are more than 400, what happens is that most often your VLDL level will go up. If you follow the Fredwald equation, then it will give a wrong low estimate of your LDL. So always when the triglyceride is high, always ask for a direct estimation of LDL. Most of the laboratories will do a direct when the triglyceride is high, but small laboratories, they can go wrong. Sometimes HDL is also calculated. Total cholesterol divided by 4, they calculate the HDL. Some small laboratories are doing this mistake, so we have to be very careful when interpreting these values. So again, I will just touch upon the creatinine value at last. I think we have 2 more minutes. So when you are interpreting a creatinine value, always keep in mind the creatinine level depends upon the muscle mass. The more the muscle mass, higher the creatinine will be, even in spite of normal renal function. And again, age is an important thing. Young age, high muscle mass, males, they all have a high creatinine level, even with the presence of a normal renal function. But on the other hand, when it is female, when the muscle mass is too very low, elderly female, 70 years, 75 years, even if the creatinine is 1, still they will be having an advanced renal dysfunction. This is what we have to keep in mind. And again, hydration status is very important. In dehydration, the creatinine levels actually go up. In fluid overload, the creatinine levels, because of dilution, it can come down. And again, dietary influence also are there, and creatinine, high protein intake can actually elevate the creatinine value. And sometimes vegetarian diet can reduce, because creatine will not be there. So vegetarian diets can favor reduced creatinine level, and we all know about the nephrotoxic drugs which can elevate your creatinine. I'm not going into those details. And again, there is differentiation between the methods. Jaff's kinetic method was the previous method which they have been using. When you do this, there will be so many interference with the other substances which can falsely interpret your creatinine value. So the better method will be an enzymatic method. And we know that there are physiological fluctuations. You can see after an exercise, after any large meal, after a minor dehydration, all these things can impact your creatinine value. So to conclude, what I want to tell you is that we heavily depend upon the biochemical parameters in guiding our patients, but there are certain caveats. If we do not consider these caveats, there are the caveats in the form of physiological factors, pathological factors, and laboratory factors. All these things can alter these values. If you do not consider these caveats, what will happen? Most often, there will be misdiagnosis, or there will be under-treatment, or sometimes there will be over-treatment in this patient. So with this, I end my talk. Thank you. Over to the chairperson.
We know type 1 diabetes is the a common cause of DKA, but we see certain patients presenting like features with the type 2 diabetes, but they developed this ketosis, sudden ketosis. Otherwise, it is known as flatbush diabetes or one-and-a-half diabetes. We have divided into 4 different types. To talk more about this, we have Professor Dr. G. Prakash, MD, DIP Diabetology, FACP, is a professor and the head of the Department of Diabetology, Government Mohan Kumaramangalam Medical College and Hospital, Salem. Over to you, sir.
Good morning, one and all. At the outset, I thank the organizing team for having invited me here to deliver this lecture on ketosis-prone diabetes mellitus. It's an atypical form of diabetes mellitus. Since R is a tertiary care institute, we come across atypical diabetes like this in younger individuals. So this is a 23-year-old female, came with complaints of polyuria, giddiness, vomiting, abdominal pain, breathlessness, and generalized fatigability for the past 3 days. She had a history of diabetes 6 months back, but she didn't get any treatment. And family history, her mother was diagnosed as type 2 diabetes recently, just after her diagnosis. So the clinical picture depicts the patient has features of ketoacidosis. So the clinical findings are height is 150 centimeter, weight is 60 kilograms, BMI is 26.6. Patient was conscious, oriented, dehydrated, and tachypneic. And we could see extensive acanthosis nigricans with skin tags. So this is a classical feature of insulin resistance for type 2 diabetes, but she presented with DKA. Her investigation showed fasting blood sugar 300, postprandial 486, HbA1c 14.5, and acetone is positive. And ABG results came as moderate acidosis, total cholesterol 371, triglycerides 393, LDL 130. Thyroid functions were normal. So with these investigations, we managed as DKA. And after controlling blood sugar, because we need to do C-peptide only after glycemic control, after achieving glycemic state, her C-peptide came as 0.25. When we calculated her serum insulin, it came around 46, and HOMA insulin resistance was on the higher side, but HOMA beta is on middle. But the rest of the investigations were normal. So this is a case presenting with DKA. The moment we think, we immediately say it is a type 1 diabetes with DKA, but her clinical findings depicts she has insulin resistance, having acanthosis nigricans, and HOMA insulin resistance calculation is 25.7. So she was treated as per DKA management, and she was discharged. She was discharged with the dose of basal bolus regimen, that is short acting before each meals and basal insulin at bedtime. She required almost 105 units, and since she had features of insulin resistance, we had added metformin. And after discharge, she had recurrent admissions with twice for mild DKA, but without any precipitating factor. Spontaneous ketosis is a characteristic feature of type 1. It's very rare in type 2. A precipitating event only precipitate DKA in type 2. So this is an entity which had been highlighted recently, even in recent diabetes care. Ketosis prone diabetes. What is this ketosis prone diabetes? It's an heterogeneous atypical form of diabetes characterized by occurrence of diabetic ketoacidosis, but without classical phenotype of either autoimmune type 1 diabetes or type 2 diabetes. So it's very difficult to classify these kind of cases. So the other terminology for this ketosis prone diabetes are flatbush diabetes, atypical diabetes, and type 1B diabetes. So we have again a classification in this ketogenic diabetes even. Previously it was called as ketogenic type 2 diabetes. Now they say it is KDM, ketosis prone diabetes mellitus. So it was, classification was based on autoimmune factors and beta cell function reserve. So if the autoantibody positive and the beta cell reserve is negative, that is less, it's typed as A plus beta negative. If the autoantibody is present and there is a beta cell functional reserve, it is classified as A plus and beta plus. If both were negative, they were classified as antibody negative and beta cell negative. If autoantibody is absent but beta cell function is present, it is classified as A negative and beta positive. So this autoimmune positive and or autoimmune negative with defective beta cell reserve, it mimics as type 1. Similarly, autoimmune positive or negative but beta cell function reserve is there, it mimics type 2. So it's very difficult to classify where it is, but the literature states that A negative and beta cell reserve contributes the largest KPD subgroup, approximately 50%. So this type of ketosis prone diabetes is predominant. So what is the pathophysiology underlying this ketosis prone diabetes? Still only hypothesis. They state that these patients do not have major HLA class 2 alleles that is susceptible to autoimmune type 1 diabetes, and there was thought that there are some genes which causes defective beta cell development or even regeneration function, and there are certain variant genes like TCF1, PAX4 and POX1 encoding H1 alpha, and another in autoimmune type 1 diabetes is beta cell response, whereas here it is T cell response. And why there is ketosis in this patient? The hypothesis is that probably due to dysregulated intermediary metabolism, that is aberrant pathway of branch chain amino acids or arginine citrulline leading to unprovoked DKA. So this might be an important hypothesis causing ketosis in this type of diabetes. So how to manage this type of diabetes? The management of DKA is similar to that of management, that is appropriate hydration, insulin infusion, if there is infection, antibiotics and potassium replacement or bicarbonate if there is severe acidosis. What to do after resolution of DKA? So the hyperglycemic management is important in this ketosis prone diabetes. The management depends upon the beta cell secretory reserve. The beta cell secretory reserve is the strongest predictor of long time management of hyperglycemia. If the beta cell function is defective, whether it is autoimmune positive or negative, these patients were dependent on insulin lifetime, just like type 1 diabetes. Coming to beta cell reserve is there, but autoimmune might be or might not be. These patients may respond to anti-diabetic drugs, but we need to be cautious because SGLT2 inhibitors, as it causes euglycemic ketosis, is contraindicated in this type of ketosis prone type 2 diabetes. So this is a study which was published last year in Diabetes Care, wherein they are pooling all the cases of this atypical diabetes in US, different universities. They named it as RADIANT study, Rare and Atypical Diabetes Network Study, where they have made design and they have included all types of atypical patient, that is which doesn't categorized as type 1 or does not categorize as type 2, and even we came across a lipodystrophic diabetes which we presented in RSDA case file, and fulminant diabetes. There are various types in adolescent and childhood. Very difficult to differentiate whether it is type 1, and now they made it as a registry and they started doing genotypic and phenotypic analysis. This will be published in another year. Thank you.
Thank you so much for explaining us the rare cases. We'll move on to the next topic is Indian adult guidelines, adult vaccination guidelines for diabetic. We know we have been, can I have the slide? Introduction slide. We know we are very clear about pediatric vaccination. We have a segment recommended by ADA and other bodies for adult vaccination, especially for immunocompromised people, diabetes. And to talk about that, we have Dr. N.S. Prasad. He's a MD physician. He's a consultant internal medicine and cardiodiabetologist in LS Nursing Home in Trichy. He's a EC member in RSSD as well. I welcome Dr. Prasad. Please come.
Good morning, everybody. I first of all thank the organizers for having given me an opportunity to be amongst you. So today's topic of discussion is vaccination for diabetic. As you are all aware, type 2 diabetes is a state of immunodeficiency. So diabetics have a higher rate of infection compared to the non-diabetic population. Over added to this, the aging process of diabetes, the various comorbid conditions which are associated with diabetes adds to the occurrence of infection in diabetes when compared to the non-diabetics. Moreover, the morbidity and mortality are associated with infections is severe in diabetics when compared to that of non-diabetics. So as a result, immunization is a means of providing specific protection against damaging pathogens. Vaccination provides novel approach to boost immunity. So this is a historical perspective. 1796, the smallpox vaccination was discovered. Now we know that smallpox is eradicated. 71, the MMR vaccine. 1988 came the polio eradication program. 2016, Ebola for a specific group of population. 2019, our memories are there about the 2019 COVID vaccination. So 2021 COVID, 2019 meningococcal. So what is the CDC's advisory committee on immunization prescribes two vaccines which are mandatory. One is influenza, other is the pneumococcal. Because we all know this pneumococcal is a vaccine, pneumococcal pneumonia is associated with lot of morbidity and mortality in the people. These are the vaccinations for adults in diabetes. So if you take hepatitis B, again it's totally an optional vaccine. If the need is there, we have to recommend. Second important is the hepatitis B. If somebody has not been vaccinated below the age of 60, definitely they require hepatitis B vaccination. Third is the Haemophilus vaccination. It is only in a selected group of people who undergone splenectomy and things like that. Next comes the papillomavirus. Again, you are aware that it is only in the people who are the female aged less than 26 or male aged less than 21. Of course, influenza we are going to talk about in detail. MMR vaccine. Now there are some recommendations that MMR booster might be given. Then meningococcal, of course, we can give it to the people only in the pediatric age group. Pneumococcal we'll talk in detail later. The Tdap again, because of there is a lot of pertussis occurring in the older population. So there is some recommendations for the booster or the pertussis vaccine at a later date. Chicken pox again, if somebody has not been vaccinated, that is also recommended. Zoster shingles. Now anybody aged more than 50, the Shingrix brand of shingles vaccine has been recommended. So the suggested criteria is, of course, for a pediatric age group, more than 2 years, pneumococcal can be given. So one thing is contraindication is the hypersensitivity to the vaccine. Third thing is for people who have got chicken egg allergy, we have to be a little bit careful whenever we administer the influenza vaccine. Patients with GB syndrome, patients who are having acute illness or acute febrile illness, we need to defer the vaccination program. So one thing is, as our chairman has already alluded, the adult vaccination is not very much structured, whereas the pediatric vaccination is very much structured. What is required is a very structured program wherein primary care physicians have to take up this in a systematic manner. Now we will go about in detail about two important vaccines, that is the pneumococcal vaccine. One is there are two types of pneumococcal vaccinations are available. One is the pneumococcal polysaccharide vaccine, referred as PPSV. Other is the pneumococcal conjugate vaccine, PCV13. So what is really recommended is a one-time revaccination is recommended for all individuals 65 years. So even if somebody has got vaccinated previously, if one is going to cross the age of 65, another dose of pneumococcal vaccination, repeat vaccination is recommended. Also people with diabetes with nephrotic syndrome, chronic renal disease or immunocompromised individual like post-transplant or a post-organ transplant, revaccination is recommended. For other people, one vaccination might be sufficient provided they are adult more than 60 years. Coming to the PPSV23, it's recommended for chronic heart disease and chronic obstructive pulmonary disease. Until 2013, only PPSV23 alone was recommended. Now this, after that, now the PCV13 is recommended. So these are the differences between the PPSV23 and PCV13. As you are all aware, the polysaccharide vaccine was the first vaccine to be, which came. The advantage is it's a good vaccine, very cost effective. But the main problem or disadvantages is that T-cell dependent immune response is only declines in 3 to 5 years and there is no amnestic response. So that is the biggest problem with the polysaccharide vaccine. Whereas if you take the PCV13, the T-cell dependent immune response is quite good. So it has significant efficacy against pneumococcal pneumonia. The only problem is the cost factor for the PCV13. So these are all the various organizations which have recommended the pneumococcal vaccination. Our RSSDI 2022 guidelines and the Geriatric Society has also recommended the pneumococcal vaccination. Coming to the pneumococcal P23 vaccination
should be offered to persons aged 19 to 64 years. A one-time revaccination is recommended for people above 65 years of age if the original vaccine was given when they are less than 65 years. So after 65 years, irrespective of whether they got vaccinated or not, a revaccination is recommended. For people with diabetes of equivalent to of more than 65 years or with immunocompromised stages, first vaccine that is suggested is the pneumococcal C13 vaccine. This is followed by at least 8 weeks later by the pneumococcal P23 vaccine. Now again, there is the pertussis is also increasing. So some of the nations are recommending pertussis booster vaccination. Again, another important vaccination which is recommended is the herpes zoster, because we find herpes zoster is occurring in a large population of people, especially diabetics, cardiovascular disease, patients with steroid use, and so on and so forth. So among the pertussis vaccine, the RSSDI has recommended the RSV is the preferred shingles vaccine due to its higher efficacy and longer duration of protection. In the Indian setting, the Shingrix vaccine is a good option for all diabetics 50 years or older. So that is also recommended. Now coming to the another important vaccine, that is the influenza vaccine. So we have got two varieties of influenza vaccine. One is the killed trivalent activated influenza vaccine. Other is the live attenuated influenza vaccine. The live attenuated influenza vaccine is quite effective and it is recommended. The live attenuated vaccine is a trivalent vaccine. So it contains two influenza A strain, one H1N1 type, one H3N2 strain, and it contains one type of a beta strain. So all this is decided by the WHO. What the strain is decided by the WHO based upon the epidemiologic and antigenic analysis of the currently circulating strain. So each year, the composition of the strains in the influenza vaccine will change, because this is a vaccination which needs to be given every year at the start of the monsoon season, say maybe September or October. So again, the annual vaccination against influenza is recommended for all adult diabetics. It's available as 0.5 ml liquid pre-filled syringe given as intramuscular injection in the deltoid muscles. So the American Heart Association, Diabetic Association, in our initial evaluation of a patient has recommended that we should ask for the vaccination history and the needs. So this is what they recommended. So to summarize, the burden of vaccine is preventable disease among the adults. The impact of vaccination for adults is high, and vaccines are widely available but underutilized by adults. Implementation of the standard for adult immunization practice, talk to adult patients about vaccines, implement evidence-based interventions to promote vaccination for adults. Ensure that adults are up to date on recommended vaccines to help adults stay healthy and prevent hospitalization, disability, premature deaths. The key adult immunization facts are there are a lot of challenges for adult immunization. That is, vaccine coverage among adults is unacceptably low. Limited patient awareness about the need for vaccine among adults. Adult vaccinations less integrated into the clinical practice. So we require a total integration of the adult vaccination program in all our health programs. The opportunities are most patients willing to get vaccinated when recommended by medical providers. So we as primary care physicians and diabetologists, we need to recommend suitably to our patients the need for vaccination. Primary care providers believe that immunizations are an important part of the services that they provide to patients. the systemic offering and recommendations from clinicians result in a higher uptake. So we should be the guiding light in initiating vaccination for our patients. To conclude, persons with diabetes often have comorbid factors which increase morbidity and mortality from infection. In addition to glucose management is more difficult when illness is present. We all know that whenever the patient has got any infection, his hyperglycemic status is high and it might be difficult to control the infection. So, vaccines are among the most cost-effective clinical preventive services and the core component of the preventive services package. Adults with diabetes should routinely receive vaccines as recommended by the ADA 2019 standards of medical care in diabetes and the CDC. Thank you for your patient hearing.
Adult vaccination, and the forum is open for questions.
I'll ask questions. So with the permission of the chairpersons, I have a question for each speaker. So first question to Dr. R.P. Rajesh. No, he's here only. I won't let him go. Sir, my question is very simple. You had put some formula for calculation of LDL. So in your opinion, which is the best method?
See, first of all, I think Fredwold is a very easy method to calculate an LDL, because it is very easy to estimate total cholesterol in a laboratory, as well as by direct method we can calculate the HDL. Only thing for triglyceride, for the VLDL, we have to divide the triglyceride by 5, as long as the triglyceride is less than 400 milligrams per deciliter. So if that is there, you already have total cholesterol value, you have the HDL value as well as the VLDL value. Just subtract the VLDL and HDL from the total cholesterol, what you get is the LDL. So this will be preferably better and easily method which is being adopted. But only caveat is that when the triglyceride is on the higher side, what happens? If you divide by 5, the VLDL value will actually go up. And if the VLDL value is more, obviously when you subtract it from the total cholesterol, obviously you will get a very, very low LDL value, which will not actually be the exact picture. Or even sometimes negative also. There are labs reported 2.3, 6.4 like that values are LDL are there. Not all the labs, but some small labs are being reported like that. And to add salt to the wound, I already told you, even the HDL values are also calculated in some labs. I have asked the lab technicians, they have told, no sir, we will calculate the total the total cholesterol and divide the total cholesterol by 4, which is always not possible. If you have a cholesterol of 200, when you divide it by 450, there are some lab technicians who have told me, while I was interviewing them, they told me this is the practice we have in our place. So always when the triglyceride is elevated, we have to go for an LDL, direct LDL estimation method, but this is not always recommended. The reason is that most of the times when the triglyceride is within the normal range or not so very elevated, what happens is that there is not a big discordance between the calculated LDL and the estimated LDL. The problem goes only because when you want to do an LDL estimation, what happens? It is expensive and the procedure is cumbersome, and again, it is not always needed. When the triglyceride is normal, it correlates, the calculated value actually correlates with the direct estimation value, so probably the formula will work out there. But always look into the triglyceride level. When the triglyceride level is very high, always, even if the lab has not done a direct value, you actually ask for a direct LDL value.
So what should be the cutoff point that we can rely on triglyceride or not to rely on?
Maybe up to 400 we can.
But 400 also might be.
That is also
higher.
high. That is also high. See, it's a gray line, gray area. But we have to define some value. For that reason.
It around 200.
See, that is why in certain conditions, always direct estimation of LDL is good. For example, in patients with diabetes, we often see very high triglyceride levels. There are so many reasons, because the triglyceride clearance is actually less there, and production of triglyceride is more because lipolysis will be there, more and more free fatty acid production will be there, so triglyceride levels will actually go up in diabetes. So in nephrotic syndrome, in all these certain conditions where you expect a high triglyceride level, always go for a direct estimation. So in diabetes, if you have any difference in your triglyceride, especially when they are checking a non-fasting lipid profile, always go for, see, when you do a non-fasting lipid profile, what will happen after the food intake, what will happen, the triglyceride level will actually go up. Where it is supposed to, where it is actually less than 150, it can even go up to 300 when you do it in the postprandial state. So in that time, when you are going to estimate the LDL by a formula, I think that will not be good there. So when
in
you
that case, can we say like ask for a non-fasting with a direct LDL measurement?
Yes. When you are going, see, non-fasting is very important. We know that atherosclerosis is actually a postprandial event, and we know that we spend most of the time in the postprandial period. So when you do a non-fasting lipid profile, that will be even more apt.
Provided we do a direct LDL.
Yes.
That should be the...
No other parameters will get affected when you are going to do a non-fasting lipid profile. The only parameter which gets affected will be your triglyceride. And when you do a calculated method, what happens? Obviously, the LDL will be grossly low in these patients.
Okay, sir. So another question. So when do you suspect like the strips are outdated? Like how do you know, like suppose the random samples are showing abnormal values or normal values? When do you instruct your patients? Probably you need to change your glucometer strips.
Yeah, probably. See, every strip comes with an expiry date. So when the expiry date is over, we cannot use it. But again, what we usually recommend is that we see most of the patients, if they are doing, if only single person is using glucometer at home, we don't recommend them to buy 100 strips at a time, because hardly they check only 4 times a month. Probably once a week they may be checking. So if they are using the strips, see, if they if they're opening and closing it, even moisture will actually impair the values. So that is also important. So beyond the expiry date, they are not supposed to use it. And apart from that, I don't know what else could be there. Yes, sir.
Once you open the lid,
yeah.
About maximum 3 months you can use.
Yes.
Beyond that you cannot use.
Okay. Yes, ma'am.
Thank you, Dr. R.P. Rajesh. Now, my question to Dr. Prakash, sir. Sir, you said that the most common group with ketosis-prone diabetes is those who are autoimmune negative and beta cell positive. So this will include all our type 2 patients.
See, type 2 diabetes, do you come across spontaneous ketosis in type 2? Only when there is a triggering factor like infection or acute stressful events will trigger DKA in type 2. Whereas type 1, spontaneous ketosis. So typically this atypical diabetes, although it looks like type 2, but without any triggering factor, ketosis occur.
Sir, regarding the estimation, we are talking the first cavity in biochemical reports in diabetes. Lot of labs give fructosamine values. Number 1, what is the relevance? Number 2, we come across only HPLC is suggested, and you have to ask the lab or send your patient to the lab where they're doing that. So you can avoid all these confusions.
Yes, sir. Fructosamine values becomes more important during pregnancy. So that gives you an estimate of your last 2-week blood glucose value.
But in all the regular methods where I'm asking for a diabetic basic profile, they give these fructosamine values. Okay. So I don't know what it is. And fructosamine values. And another one, sir, non-HDL cholesterol is also very important, which is very important. And I think so, as you rightly said, if it crosses more than 400 and 500, you think about a direct estimation LDL. Otherwise, you can just ignore it. In the fasting state, if you want to take, make sure the patient has not taken alcohol the previous night. Yes. It will just surge up or shoot up. So that is also very important, sir.
Yes, sir.
And the cutoff values for each parameter. Let us say for triglyceride 150, and for serum cholesterol 150, and HDL for males more than 40, HDL in females more than 50, LDL ideal is less than 100. If the patient has got already a problem less than 70 or 55, even if it's very problematic, you can go up to 10 or 20 also. There's no problem. So these things should be asked by the doctor to the lab to bring down the value. Because I see time and again, normal value, abnormal more than 250. This is all some 40, 50 years ago. And these things should be taken into account. And the doctors who are prescribing this type of prescriptions should give an awareness to the laboratories. Sir, regarding the adult vaccination, sir.
Just a second. I welcome our Professor Seshia sir, our Bhishma Pitama of diabetology. Very blessed to have you here, sir. Thank you so much, sir.
Sir, regarding the vaccination, sir, I really believe that all people who practice diabetology should take some time and talk to the patient about the vaccination. I don't think so many of the people are very hurry-burry, the patients. They have 50 tokens, 100 tokens, just giving away, dispensing some medicine as if you're giving some prasadam in the temple. So that should not be there. So you have to sit and talk. It may take some time. Accordingly, you charge the patient. I'm not asking you to do free service to anyone, because we are not coming to the profession free. So that is important. Say, all my patients, I advise pneumococcal vaccine. There's no doubt about it. And over the age of 50 or 60, definitely Shingrix. We don't know when it will strike. It is better to die rather than have shingles, because the amount of pain you suffer, I've seen some of my colleagues' own family members committed suicide. So that is also very important. And regarding Tdap, I think so, it is not picked up in the market. I think so you have to give more importance to Tdap, because prevention is better than care. One shot of streptococcal pneumonia, sir, it's the end of your bank, whatever balance you are having. So I think so 4,000 rupees is not a big amount in the MRP, but if you get it on the wholesale market, you're just 3,200 only, sir. So I feel that all the doctors should take up in a very serious manner, sir.
That was what I also stressed in my talk also. So we need more structured way, just like pediatric vaccination is structured. Our all primary care physicians and diabetologists should structure the vaccination program also as part of their treatment curriculum. It's not like therapeutically treating only the blood glucose alone or the lipids alone and things like that.
It's very important, sir.
Yes,
Thank you, sir.
Thank you.